Well, hello, everybody. It's a real pleasure to be chairing this session of one of the HIAAD Bridge seminars. I'm particularly pleased today to be working in a seminar with two of my very close friends and colleagues in the field who I've known for many years and I truly admire. So we will have a discussion today about managing agitation. You will hear about the frequency of agitation and how problematic it is for people with dementia. It's also an exemplar of the many other neuropsychiatric symptoms that patients develop. And for those of us who operate in the clinical world, this is a very concerning and problematic condition that we generally have two modes of approach. One is non-pharmacologic and the other is pharmacologic. And obviously you will appreciate that they are not mutually exclusive, but we're framing it today as a little bit of a debate so that we can figure out how we navigate the waters in choosing when to try and stop non-pharmacologic approaches, how to use medications, and so forth. So with that introduction, the framing of this discussion will be as follows. Dr. Porsteinsson, who is a professor at the University of Rochester, will be giving a brief presentation on the epidemiology, setting the framework. He will then pass it on to Professor Kales, who is the head and chair of psychiatry at University of California, Davies, formerly at the University of Michigan, and she's got many Greek genes, as you will appreciate. Anton, on the other hand, is an honorary Greek, so this is an all-Greek symposium today. So Dr. Kales, who has pioneered some of the approaches to managing behavioral symptoms, will be talking about that, especially the DICE approach and how to initiate and monitor non-pharmacologic approaches. She will pass the ball back to Anton, who will talk a bit about medicines and how to choose them. Our goal is to have those three brief presentations completed by about 40-ish minutes into the hour so that we have 20 solid minutes for a conversation. So without further ado, Dr. Porsteinsson.
Okay, let me share my screen here. About making this work. Okay, that should work. You should see my screen now. Anyway, so I'm going to start by talking briefly about the scope of the problem of agitation. And so dementia of different etiologies is very commonly associated with behavior and psychological disturbances that we often referred to as neuropsychiatric features. Some of the most common are actually apathy and then depression and anxiety, but maybe the most challenging for treatment tend to be agitation and aggression, as well as psychotic symptoms, hallucinations, and delusions. And if you look at the course of dementia, and we can actually talk about the preclinical stage where you have no symptoms, the mild cognitive impairment state where you have just kind of minor impairment in cognition and little functional impairment or none, as well as the different stages of dementia. And we're going to focus quite a bit on Alzheimer's disease here, so mild, moderate, or severe dementia. The neuropsychiatric symptoms are near ubiquitous, that the vast majority of people with dementia will develop one of these neuropsychiatric conditions at some point. during their disease state. So the prevalence estimates are 60 to 80%, and a lot of that framework has been laid by Dr. Lyketsos. And the lifetime risk is well over 90%, almost 100%. And neuropsychiatric symptoms, if you talk to both patients, but especially their caregivers, their care partners, are some of the most distressing elements of dementia as an illness. It leads to significant decrease in well-being and increases distress in the patients. It increases the distress for caregivers very significantly, and it's associated with numerous bad outcomes. So worse functional and cognitive deficits and more rapid progression. Earlier institutionalizations, and that can be visits to emergency rooms, hospitalizations, admissions to nursing homes, or memory disorder units. So there's a lot of consequences associated with neuropsychiatric symptoms. Whereas neuropsychiatric symptoms are kind of, unpredictable in terms of they're often kind of combined in a mishmash of symptoms. They tend to present themselves in fairly predictable patterns. And it may differ for some of the symptoms that I mentioned earlier. So if you look, for example, at the very early clinical stages or preclinical stages, where there are almost no cognitive symptoms, you can see an increase in anxiety, more depressive features, more irritability. As the disease wears on, you start to see more of apathy, and you also start to see more, conversely, agitation, aggression, and psychosis. And like I said, there's a lot of co-occurrence. We can have anxiety and depressive features mixed in with agitation or mixed in with psychosis. So there are high rates of co-occurrence, and apathy is pretty common with all of these. But one of the problematic co-occurrence is the combination of agitation and psychosis. So if we look at those two conditions, the incidence rates are about 20 to 40% after you follow people for 1 year, and 50 to 60% if you follow people for 2 years. And there's a high rate of persistence. If you develop agitation and aggression, you follow these individuals for a year, and there is no meaningful intervention or treatment. 60 to 80% of the people that had agitation or aggression at the start of the year will have that at the end of the year. So they have quite a bit of endurance. So like I said, we often think about neuropsychiatric symptoms as something that emerges kind of more in the moderate or the late stages of Alzheimer's disease or other dementias. And it's true that they become more common as the dementia progresses, but they actually can happen very, very early. And if they're in kind of the very early stage, like the preclinical stage, we actually refer to it as minimal brain impairment or minimal behavior impairment. So MBI. And that's work that Zainer Ismail and Dr. Lyketsos have kind of pioneered. I've already talked about some of the bad outcomes with this, but what I didn't mention is the increase in cost that is associated with the emergence of neuropsychiatric symptoms, partly because they have to be treated, partly because you need to bring in extra resources, and partly because every other aspect of your medical management gets more complicated and expensive. If you have diabetes, if you have cancer, if you have heart disease, and you're agitated and aggressive, it's hard to take care of you, and you're often resistant to taking medications. So one thing that I want to point out is that, what does agitation look like? And words, and especially words across racial, ethnic groups, countries, may not fully capture this. So agitation, when we look at the definitions like the IPA, International Psychogeriatric Association, it is characterized by increased motor activity, so restlessness, emotional distress, and aggression. And the aggression can be verbal and it can be physical. Agitation can happen without aggression. We often combine these, but they don't necessarily always go hand in hand. So they can be separate. So examples of agitation without aggression might be pacing, rocking, and repetitive behavior. There's often a lack of awareness of neuropsychiatric symptoms in caregivers. They kind of aren't sure, is this part of an illness? Is this just, my loved one getting more ornery as they get older? Is it something to be concerned about? So they often don't bring it up to providers. So it's very important to ask if there have been changes in personality or changes in behavior. And Dr. Kales will cover that in more details later. And so it's not like having a fever or having a headache. Care partners and caregivers are often unclear how they should do it. And they often use language that, is not very well defined, and they don't understand our medical terminology. So it's very, very important to kind of get people to give you descriptions. What's going on? What is distressing? What's distressing for the patient? What's distressing for you? How does this happen? When does that happen? And we'll hear a lot more about that. It's incredibly important to do the right type of work. So the IPA definition for agitation, basically, like I said before, someone needs to have a cognitive impairment or dementia. They have to have behaviors that cause distress and happen frequently, an emergency alert. They cause excess disability, and they can be due to a established psychiatric disorder or medical condition. So excessive motor activity, here are some of the examples: pacing, rocking, gesturing, pointing fingers, restlessness, repetitious mannerism, verbal aggression, yelling, speaking in a very loud voice, using profanity, screaming, shouting, and physical aggression, grabbing, shoving, pushing, resisting, hitting others, etc. You kind of get the point. I do think that irritability and oppositional behavior kind of falls into this field very much as well, and maybe isn't captured as well in the IPA criteria as we should. So with that, I'm going to hand things over to Dr. Kales. I'm going to stop sharing, and please go ahead, Helen.
All right. So I've provocatively entitled my piece, which has to do with non-pharmacologic management, Titha Kaname Meti Yaya. So we're going to set the stage here with a little case of Yaya Tina, who's a 76-year-old woman. She has moderate dementia. She lives with her daughter Athena, her son-in-law, and their grandchildren. And she's hired a caregiver to help her during the day when the family goes to work and to school. And so she, if you see the picture there, Yaya Tina is throwing a pillow at Jane. And Athena ends up calling the primary doctor saying, my mother's getting agitated with the caregiver. She's about to quit. Can you prescribe something to calm my mother down? So, Anton set me up nicely for this. I think when we have a physical symptom, we often have a straight shot there to the physician. And so you might have something like, Yaya has shortness of breath. Now, if the physician said, well, I'll write for an antibiotic right now, we would say that's malpractice, because in reality, what happens is our physicians go through, and you're not meant to see this, algorithms. And so depending on what the lab findings are and the physical findings and the history and the physical, the physician's going to go down multiple different paths. So if it's thought to be a pulmonary embolus, there's one path. If it's pneumonia, it's another path. But you see that shortness of breath, which is a vague symptom, isn't followed by one path. Conversely, what we have with behavior is you'll hear something from a caregiver like Yaya's agitated, or I need something to calm her down. Or sometimes we even get caregivers who ask us for a specific medication and dose. And often what we get from the physician is, well, I'll write for something now. So as opposed to the algorithm that we see on the right, we get a sort of straight shot from agitation to a psychotropic medication. And with the advent of brexpiprazole getting the indication for agitation in the US, that straight line may be even more straight. And so we like to think about agitation, and this is an overly complex diagram, but Kostas and I and Laura Gitlin created this for an NIA, NIMH expert consensus panel several years ago, with the thought that at the basis of behaviors like agitation is the neurodegeneration we see in patients in the brain, and that one can see a direct pathway to behavior with behaviors like apathy, where we know that there are specific brain circuitry disruptions, but that in others, often like agitation, there's a vulnerability to stressors or triggers that are at the bottom of the graph there that include patient factors, caregiver factors, or environmental factors. And what we believe is that those factors are inherently modifiable. For example, if somebody has pain, you don't want to mistakenly treat them with brexpiprazole. You want to treat the pain condition. Or if somebody has a caregiver, for example, who is expressing a lot of negative emotion, we know that that is correlated with upsurges of behavior. Yelling, screaming at the patient with dementia can be mirrored in the patient with dementia. And in the environment, a lack of light, for example, can create the scenario for poor sleep by lack of entrainment of circadian rhythms, depression, lack of activity and structure. So the point would be that we want to look at some of these factors to see whether we can modify them. And so what I would point out is that, and I think Anton actually set this up well with the criteria, the international criteria are actually quite broad, meant to be very sensitive for picking up agitation, but that creates an extremely heterogeneous syndrome where you have things like fidgeting and yelling also lumped in with aggression, and that behaviors are often a communication of a problem in the caregiver, person with dementia, environmental dyad. the use of medications is often found to be more related, actually, in studies that we and others have done, to the degree of caregiver distress than the severity of behavioral symptoms. So if you will, at times you are actually treating the caregiver as opposed to the person with dementia. And an issue that can create is that we are treating a communication which silences it and doesn't allow us to treat underlying modifiable causes, and it doesn't allow us to use more person-centered strategies. So a number of years ago, we came up with the DICE approach. The D stands for describing the behavior that challenges. So rather than just fidgeting or yelling, we want to know what happened, who was there, when it occurred, how it occurred, and so forth. We then train caregivers to investigate, to think like a detective, explore the person with dementia, the caregivers, the environment for clues or triggers to the causes of behavior, to create a prescription in collaboration with the team that is working with the person and caregiver to prevent and manage behaviors, and then to evaluate the solutions that we come up with. So in the first stage, this is often left out. Again, we don't treat shortness of breath with antibiotics without any other history, physical or labs. So when we hear that Yaya gets so agitated with the caregiver, we actually want the caregiver, and I credit Kostas with this, this aspect of DICE, we want to train them to play it back for us like a scene from a movie. And of course, now we have caregivers who actually come in and they do play it for us on our phones or their phones. So again, you know, we want what happened during the scene, so to speak. And so I'm just going to play you a very brief clip to show you Yaya and what she is doing. So we are actually seeing what Jane and Athena are seeing.
Tina, it's time to wake up. Let's go to the bathroom to clean up. Let's get out of bed. I don't want to get out of bed. I don't want to get ready. Come on, not again. Please don't give me a hard time. Your bed is wet. You need to wash up. It's 9 a.m. It's time for your breakfast and medication. I don't feel like it. I don't need your help. Stop it and calm down. Don't touch me. How dare you telling me what to do? I don't need your help. I am just doing my job. Let's get ready for the day. I don't need.
So you get the flavor of, rather than just agitation, we can more fully describe the problem. So we have Yaya Tina, she's in bed. When Jane walks in, her eyes are closed. She might be surprised, sorry, not Maria, but Jane, entering her room, maybe disoriented. She gets angry, shouts at one point, "Leave me alone, don't touch me." She gets physical by throwing the pillow and actually then escalates to hitting Jane. You know, not that hard, but it occurs. And then Jane, for her part, is kind of rushing into the room. She seems a bit overburdened. She sighs when she walks in. She's already on edge. There's no introduction to the tasks that are going to happen. And then she starts listing the multiple things that have to happen. She's a little confrontational. Your bed is wet. Stop it. Calm down. And we see that in the environment, the light in the room may not be optimal to cueing waking up and morning routines. And we wonder, is there any structure or routine to Tina's mornings? That will seg into our next step, which is investigate, where we want our caregivers to play detective, finding triggers from one or more of the three categories. And this is just the low-hanging fruit that I'm listing here, but could be pain. We often look for constipation, a UTI, especially in women, recent changes in medications, caregiver factors like reacting harshly, feeling stressed, offering too many choices, and then looking at the environment. So here with Yaya Tina, we find out she has a history of bipolar disorder. She's on low-dose lithium. She's taking ditropan for incontinence. Could there be some anticholinergic effect? some history of UTIs, also type 2 diabetes. And an important question is to ask, is her safety at risk? And I would say no, she's in bed, she's not going to fall. For Jane, communication may not be optimal. There's somewhat of a negative slant here, little critical, confrontational, may not have education about the stages of dementia as she's rattling off multi-step commands. A number of caregivers may view behaviors as on purpose or volitional, so we want to find that out. Is her safety at risk? What she would tell us is, you know, she didn't like getting hit by the pillow, but it wasn't anything harmful. And then again, in the environment, we see a lack of structure and cues. So for creating interventions, we look at sort of 6 low-hanging fruit areas: managing any physical problems we find, providing education and support to caregivers, improving communication, creating meaningful activities, simplifying tasks, and making sure the environment is safe. And so in this case, we might have Tina work with her PCP, replace the ditropan with a more bladder selective agent, check some labs, including her lithium level would be important, her TSH, BUN, and creatinine. And also note that low blood sugars pre-breakfast could be triggering some irritability. We definitely want to work with Jane on some psychoeducation, on dementia stages and simplifying her communications, playing the role of a positive caregiver, replacing some of those negative tones, setting the stage for communication, kindness, and making sure that she feels safe if things escalate. We want to increase the amount of natural light in the morning for cueing and create some structure around the morning routine. So this is what that might look like.
Good morning, Tina. This is Jane, your caregiver. Your breakfast is ready. Would you like to eat downstairs?
I like my bed. I want to stay here. You can bring my breakfast here in bed.
I can do that. I see that your bed is wet, though. I would like to make your bed so you can rest comfortably. Meanwhile, would you like to eat at the dining table?
No, I want to have my food here in bed.
Okay, how about if you eat right over here, just while I make your bed?
Okay, fine.
So, and we can discuss the intervention later during the discussion, but you know, one will see that she did a lot of nodding even when she was disagreeing with Tina and kind of getting her to move on some of the behavior. We then want to evaluate our interventions. Did some of the medication changes or physical changes impact behavior? Did adjusting lithium impact behavior? For Jane, were we able to increase her understanding of dementia stages? And was she able, and I would say by the clip we just saw, she was able to improve the quality of her communication. What impact did creating some structure and activity have? Having that little breakfast table there seems to have been helpful. So I'm going to stop sharing as well. And Kostas, I'll let you coordinate the next portion.
Wonderful job, Helen. Thank you. I love the videos. This was a good choice. So Anton, back to you to pick up. And so DICE has been applied, progress has been made, but the agitation isn't better. At what point do we start thinking medication, and how do we approach that?
So let's talk about medications, and medications are very, very commonly used. I think that is an important point here, and there isn't often a very well thought out kind of selection process behind that. So what are some of the medications that we see used? Sometimes the cholinesterase inhibitors or memantine, widely used across the world are antipsychotics. both conventional antipsychotics as well as atypical antipsychotics, various antidepressants. Prazosin has seen use, analgesics, and sometimes analgesics where there isn't really a very clear picture of pain. Mood stabilizing anticonvulsants, benzodiazepines, and increasingly, especially in countries where cannabinoids have been made legal, we're seeing them being applied. So if we look at the behaviors, when do non-pharmacological interventions work best? Usually when there's not a safety concern, or when there is kind of the behaviors are more kind of mild or moderate in terms of their intensity or their frequency. So medications come into play more as we go into the more kind of moderate to severe intensity of behaviors. And I do think it is important to kind of look at simply medications are not always required. In fact, where I see behaviors like agitation and aggression, I would say that in up to 50% of people, I don't go to medications that are specifically added on to treat the aggression or agitation. You can get away without treatment, pharmacological treatment. But often there are reasons to intervene because the non-pharmacological interventions are either not effective enough, or there just isn't the sophistication in the system or availability to do it appropriately. So you may have to default to medications. So let's look at some of the medications that are used. Like I said, antipsychotics are widely used, and this will be a little bit US-centric. If we look at here in the United States, we have one medication that is approved for the treatment of agitation and aggression, and that's brexpiprazole. If you look at data for antipsychotics in general, antipsychotics have a pretty modest efficacy for neuropsychiatric disorders in general. Despite that, they are probably worldwide the most commonly used medications, and they're used off-label in this instance. And the problem with that is the limited efficacy on one end, but very well established serious potential complications. And therefore, the risk and benefit of using antipsychotics has to be really thought through before initiation. Maybe the best known here in the US and worldwide is the so-called boxed warning. And that is that antipsychotics, when used in people with dementia, are associated with increased risk of all-cause mortality. So that's death from any cause, as well as increased risk from cerebrovascular events and cognitive worsening, falls, and multiple other concerning side effects. Let's look quickly at the brexpiprazole. There were 3 main studies done of brexpiprazole, and the first 2 studies kind of were ultimately supportive of the pivotal study that looked at brexpiprazole 2 and or 3 milligram dose over the course of 12 weeks. And in a group of people that had agitation that was tinged with aggression. The group was enriched for the presence of aggression, and that's important to keep in mind. It was a pretty behaviorally disrupted population that then was treated with brexpiprazole, 0.5 milligram a day for a week, 1 milligram per day for a week, and then the dose was increased to the therapeutic effective dose of 2 milligrams, and then subsequently, if needed, the dose could be increased to 3 milligrams at least 2 weeks after that. Both drug and placebo, and that shows you that non-pharm interventions work because there was intensive psychosocial intervention and contact over the duration of the study. And you saw a very substantial decrease in severity of behaviors as measured by the CMAI, or Cohen-Mansfield Agitation Inventory, both in the placebo group and the drug group. The drug group separated from the placebo group. It was statistically significant. The overall size of the effect was modest, and us kind of providers often argue where was that very clinically meaningful or not. But basically, this was what led to the approval from the Food and Drug Administration for brexpiprazole. I already talked about dosing. Brexpiprazole tends to have low risk of extrapyramidal symptoms and particularly akathisia. So that was kind of what made that drug appealing for this purpose. But still, there's definitely side effect burden, headache, dizziness, increased urinary tract infections, and upper respiratory infections, and sleep disturbances. Some people may become somnolent, others may become insomnia. And brexpiprazole does retain the black box warning, and there's a specific warning not to that it's not approved and not to use it for people that have Alzheimer's disease psychosis. It also doesn't work very well as an as-needed medication, has low benefit in that, and not approved for non-Alzheimer's dementia. You need to also be aware of its metabolism in the liver, and that you may need to use lower doses if combined with strong cytochrome P450 2D6 inhibitors like paroxetine, or strong 3A4 inhibitors, and higher dose if there's a CYP3A4 inducers on board like carbamazepine. In general, the American Psychiatric Association recognizes that atypical antipsychotics other than brexpiprazole are used quite commonly. Brexpiprazole is quite expensive here in the US. And people that don't have the means or the ability for coverage often ask if there are cheaper options available. And it really requires a very personalized approach and monitoring. And if symptoms are not getting meaningfully better, to withdraw treatment and to remember that not to keep people on these medications forever. You can use the DICE approach, actually. I'm going to usurp that from Dr. Kales and say you can use that here, especially the kind of evaluation and the reassessment. So remember to document the target signs and symptoms. Remember the behavioral and environmental interventions. If the medications are needed, what's the appropriate medication? We still kind of often use the therapeutic metaphor. If it is more depressive flavor, maybe one of the antidepressants. If there's more psychotic features, maybe one of the antipsychotics. You got to educate about the potential benefits and risk. Be clear about where, when are we going to make decisions about when to continue or withdraw treatment? Maintain, clear communications, which often, because our appointments, we can't see people frequently enough, that they need to be able to communicate to you through messages in the medical record or phone calls or otherwise. Use low doses, start low, go slow in terms of the increase, but push the dose if needed, and make sure that you understand that this is a team approach, that the provider team needs to kind of be on board. But there are drugs other than antipsychotics. There's increasing interest in dextromethorphan. That's the cough syrup. That actually, when combined with a metabolic inhibitor, basically raises the plasma levels of dextromethorphan, gets greater brain penetration, and dextromethorphan has multiple impacts in the brain. It's and can impact sigma-1 receptors, NMDA receptors, serotonin or norepinephrine receptors. And dextromethorphan combined with bupropion or AXS-05 is being submitted to the FDA for approval. And there's a positive study that was placebo-controlled from about 2020, and you see that there was again improvement in both placebo and drug, and it's not just because of the bupropion. It's actually the dextromethorphan that seems to bring the potential benefit. And this was replicated in a relapse prevention study that followed, called Accord-1. And just recently, at the end of last year, it showed, though, that it's not a silver bullet. There was another double-blind placebo-controlled study that didn't show a statistical superiority for AXS-05 or DMBUP, but they did another relapse prevention study from the responders in that group that showed this similar pattern to here. So we'll see what the FDA says about that. Citalopram is actually was shown back in the 2010 to 2014 to be a potential treatment, not without potential complications in terms of QTc prolongation and mild cognitive worsening, but they seem to work particularly in people that had more of an effective clinical picture, so more anxiety and depressive features. We followed this up with the so-called escitalopram trial or ESCITAT trial, because it appeared that the benefits were more associated with the S isomer of citalopram and the complications with the R isomer. But the ESCITAT trial was recently completed, and data presented last year, and did not separate from placebo. Also had a higher rate of falls and a modest QTc prolongation. There were some limitations to the study in terms of we didn't get the numbers that we set out to recruit. It's hard to recruit this population, but there's we went out with the aim to show that escitalopram would be better than citalopram, and we can say that there's no evidence of that. And we also, like I said, we didn't separate from placebo, again, showing that a psychosocial intervention can be quite beneficial. I'm going to quickly go over some other treatments. There's insufficient evidence to recommend prazosin as an intervention. There's insufficient evidence to recommend anabolone, which is a synthetic cannabinoid. There was a recent study from Hopkins with dronabinol, which is referred to as the THC-80 study, that actually showed benefit from this kind of synthetic THC in terms of measures of behavior, and it was reasonably well tolerated without impairment in cognition or function. So again, the interest in cannabinoids, both THC and kind of the non and the kind of cannabinoids that don't have the psychogenic impact of THC are gaining some attention. There's a study actually using THC at the end of life in people that are in hospice, and that is ongoing right now as well. Lack of evidence for benefit of mirtazapine that is often used. And so in conclusion, I just want to point out that a lot of medications have been thrown at this problem. And few have kind of measured up in a very convincing manner. That doesn't change the fact that they're widely used, and probably appropriately in some instances where they're clearly needed, and so we can debate that in more details. Would I say that you can kind of skip the dice and the non-farm? Well, if you do it at your own risk, but I will rather make a statement that the people that have more intense behavioral disruptions are likely to require medication. So I'm going to stop sharing here and open this up for conversation, questions.
Thank you very much, Anton. Very nice coverage of medication waterfront in limited time. I have several questions, but I will hold them because I can reach out to my colleagues at other times. So let's open it up to the floor and see if anyone has questions for Helen or Anton.
Or Helen can tell me that, I'm just full of baloney. I was going to use another word. But,
never.
Something. Thank you.
Yanni, go ahead.
Thank you very much for the nice presentations. And I understand this is complicated both in Greece and in the States and worldwide. So my question, several times I see patients and they are agitated, they are psychotic, and there's the family in desperation, and they are changing caregivers, mostly professional caregivers. Many of them here in Greece, they don't speak even Greek, so they by default this is difficult. There's a language barrier, and in many cases the patients themselves don't accept to take medication. So how do you approach this situation? In many cases, the family asks that you give medication that they give it with their food and things like that. I don't know how you approach this situation, the refusal of the patient to, and in many cases, you see, they think that the physician has some conspiracy with the caregiver, and they try to avoid medication. So what's your view on this?
Wow, you're starting with an easy one here. So clearly, in that scenario, there's so many different players, right? You're talking about the patient, you're talking about various members of the family. There's a caregiver who, as you said, and I'm familiar with this in Greece, may come from another country, may not speak English. In some of those cases, the elderly loved one is suspicious of that person, may not be very accepting of that person or the culture where they're from. So there's so many issues going on in the background. And I would say, my first emphasis in that scenario is there any safety concern, right? Is anybody at risk of getting hurt? And I should back up and say that when we created DICE, we created 3 frontline scenarios where we would use medications, and those are depression, psychosis, where there's some functional impairment, and then aggression with risk. And so if any of those would be present, I would, be inclined to use medication. And with all the provisos of everything Anton said of risks and benefits and what would be the best fit, I think in the case you're talking about, there's also the necessity of talking to the family a lot to, and I don't know if there's a term in Greek for this, but in English, we say the magic bullet. Like there's no magic bullet, and families often think that there's some medication that we have or that we're going to use, that we're going to give, or that we're withholding that could make everything better. And I think, really saying, being clear on what the target symptoms are if we're trying medication and what we hope to achieve and what may not be possible. In my own Greek family, I had my uncle bring my aunt, and she was quite paranoid and acting out in the home, and treated her with an antipsychotic. It got better. And then he said, well, you didn't take her dementia away. He was still mad, So I think being very clear on, what we're treating, what we can hope to do, what the therapeutics are. And in the case of the caregiver, hopefully imparting some of what we're doing, if it's possible, so that everybody's on the same page. Because I think in that scenario, that's going to be possibly like the weak link if we can't make some inroads there. I don't know. Anton, do you have other thoughts?
Well, Helen, before we go to Anton, let me kind of hone the question, because I think, and this is for both of you, under what circumstances might you consider using deception? Would you put it in their coffee or their juice if they are refusing, assuming the family with them?
Well, this is being recorded, so be careful.
Let's stop the recording.
So look, I'm all about the autonomy for the patient, autonomy to make decisions. But like in every other situation in medicine, if you have lost the capacity to make decisions on your own behalf, is deception worse than somebody going to the emergency room and maybe being kind of restrained and even getting IM medications, et cetera, et cetera. In a situation like this, you have to show really, really good judgment. And you need to spend the time and energy to kind of try to convince people why this might be worth doing. Even, say we're going to try this for a brief period of time. People that can't swallow medications, et cetera, they get medications that are crushed and put into ice cream or applesauce or marmalade, or I don't know what the Greek concoction would be that would be preferred. But you kind of have to think about that though, that we've got to respect every member of this, and if you're going to do this, it had better be because there is true risk of a bad outcome. If you do things for the right reasons and you document it, it's hard to question it after the fact. But if you're doing,
can I just interrupt for a second, Anton? I would also note that our colleagues not using psychotropics don't seem to have this compunction, right? Like, people give medications all the time that patients don't know that they're taking, digitalis or a diuretic or something like that. And so there does seem to be a specific issue around these medications. But I would agree with Anton that, it's always a risk-benefit analysis. And when somebody lacks capacity and there is a risk, I think the argument can be made.
So that's so there are circumstances, and I think they've been articulated, where deception might be used. In the interest of time, I'm going to open up for one last question to see if someone else has one.
There's no clinicians to ask which is more useful answer. I would like to ask.
Oh, you go ahead and ask. Yeah.
Okay, because it's more useful for for people that they really work with patients. But out of curiosity and based on the molecular biology, or let's say what we're trying to do now with exosomes with different of the HIAAD members, is there any evidence, either on biomarker or preclinical evidence, of any of the drugs we are talking about, the brain lesions related to synaptic atrophy, MRI, functional MRI, biomarkers, amyloid beta tau, on any of these drugs that very nice or let's say, drug-based or non-drug-based implications and treatment with the help, not really treatment of biological treatment, but helping the patients. Any evidence of these drugs or anything?
So let me take a quick stab at it and say there's been a lot of exploration of this, and there are, pretty clearly a lot of changes can happen in the brain. Downregulation of serotonin activity, norepinephrine can be relatively upregulated or downregulated. You can have changes in dopaminergic activity. You can have changes in glutamatergic activity. You will see changes in certain brain regions when they do very detailed MRIs, autopsy studies, et cetera. But what I can tell you is there is no decisive pattern that, this center goes wrong in Alzheimer's disease when we have that, when we have aggression, and that in dementia with Lewy body, it would be either the same center or consistently a different center. And part of it is because this is very granular, and I think that there's a tremendous individual variance. And a lot of it is you can have specific damage in one system, and then you have some downstream effects from that, and then you have a person that may have a diathesis or a vulnerability to some behavior or another emerging that can be very different for one person compared to another. Could be different depending on your gender and kind of what your hormonal background, et cetera, is. We're beginning to refine our approach to this and get more sophisticated. Blood biomarkers, which are maybe a little easier to get, but maybe not as sensitive, are beginning to emerge, because it's hard to send someone who's agitated and aggressive for a PET scan or for a very detailed MRI or a functional MRI. That's a real nightmare. But we're beginning to kind of get more sophisticated in terms of this, but that's for the future, in my opinion, at least.
Well, great discussion. I'm sure this will be watched a lot in the recording. I want to thank Professor Kales, Professor Porsteinsson for taking time to participate in this HIAAD seminar. You did exactly what we were hoping you would do, and so we're delighted that you were able to be part of it. And to everybody else, thank you for participating. Yanni, our next seminar, the first Thursday of April.
Yes, yes. Again, we will see you in 1 month with our next seminar. You will get emails with all the announcements, and we would like to have, if possible, Professor Porsteinsson and Kales with us in the next seminars for giving their feedback, because the bridges are about the clinical and preclinical bridging together. Thank you.
Thank you,
for
everybody.
including
Take
us.
care.
Everyone.
Bye-bye.
Bye-bye.